Okay, it's 2 o'clock and we're going to start the last day of the BSMT webinar. We've had some really good talks so far and I hope people have been enjoying the meeting, and if you haven't had your question answered, there's still time to send them in to us. So my name's Mark Wilkes, I'm on the BSMT committee. I'm from Rawson, London, Queen Mary University of London, and I'm the moderator for this session. First of all, I've got to thank the sponsors whose logos you will have seen around our opening slide. And if it weren't for them, we wouldn't be able to convene this webinar. And I should thank STEP Communications and Pathology in Practice for all their organization and publicizing the day. We haven't a clue how to run a webinar, but they do. Today's speakers are Tim Rawson, who unfortunately is not able to be here, but he has recorded his talk in advance. And at the end of it, Brian Dwerden, who was chairing yesterday's session, is going to come back and come in with a few comments in lieu of answering questions. Tim has agreed to answer questions later, so you can still keep them coming in and we'll collate them. All the recorded talks will be made available as in the previous days, and any questions not answered, we'll get on with them, and you will get answers in one form or another. There's just a couple of slides I wanted to introduce. This first slide that you're looking at the moment, hopefully, came from the O'Neill report. And it's got this amazing projection on the top right-hand side of deaths from antibiotic resistance reaching 10 million by 2050, which is a kind of staggering figure. And it's one that caused a lot of concern and interest at the time. And the methodological basis for arriving at that figure is not actually that rigorous. It seems to have been a back of the envelope calculation done by KPMG, who are managers basically and business experts, and perhaps not the best calculators of deaths by antimicrobial resistance. Could we have the next slide, Peter? There's just one other here. So some people have taken a slightly more rigorous approach to it and tried to estimate, will we really get 10,000 deaths a year by 2050? And the main author here, Stefan Harbath from Geneva in Switzerland, which is a very well-known group on infection control, they looked at this and tried to estimate it. And the figure they came up with is, actually, we can't come up with a figure because there are so many unknowns and so many variables that it isn't possible to predict how many people will die by the year 2050. And it's a free online article, and I'd recommend you read it just to get an idea of the difficulties of calculating things on a global scale. Okay, that's the end of me. I'm now going to get Peter to play Tim's pre-recorded talk. And at the end, we're going to get Brian Dwerden to give us a commentary and his thoughts on the talk. Okay, thank you.
Good afternoon. Thank you very much for the opportunity to be here today. And I'd like to thank the BSMT conference organisers for the invitation. I'm really grateful for the invite, and I'd like to offer my sincerest apologies for not being able to be with you to present live today. What I've been asked to talk about is antimicrobial resistance in the time of COVID-19. And I think this is a challenge and a question that many of us have been thinking about now since the pandemic came about. And before I dive into the talk today, I just wanted to start by focusing a little bit on some of the drivers and modifiable drivers of antimicrobial resistance, because I think this is an important part of AMR that we really need to consider when we're thinking about AMR in the context of COVID-19 pandemic. Now, you don't need me to tell you just how complex antibiotic resistance and antimicrobial resistance is. And in terms of trying to address this problem, which is an inevitable problem of natural selection and evolution, we know that there are a number of potential drivers which exacerbate this problem for us in terms of human and animal environmental health. And there was a publication a few years ago now from Alison Holmes and her group, which essentially demonstrated the relative contributive factors of different drivers to the development of resistance and the evidence that these were actually a major issue. And some of the things here are incredibly relevant to what we'll be discussing today, particularly in terms of misuse and overuse of antimicrobials within humans, healthcare transmission, some issues around diagnostics, as well as potentially some positive issues around the impact of travel and social contact on the transmission and development of antimicrobial resistance. And so really, as we go through the talk today, I want to think about the potential impact that COVID-19 has had on some of these modifiable drivers of antimicrobial resistance when we try to think about the question of what the impact of the pandemic is going to be overall on AMR. So today, I'm going to take a reasonably straightforward outline to the talk. I'm going to think a little bit, first of all, about bacterial infection and antimicrobial use in patients with COVID-19, because I think it's really important for us to think about the potential risks to patients from bacterial infection, how prevalent it is, and what we're seeing in terms of antimicrobial use to correlate those two factors. I'm just going to try and present some of the general evidence about what we think we know and what the remaining questions and unknowns are out there to be answered. And then I'm going to spend a little bit of time thinking about potentially some ways that we are or could address some of these gaps in our knowledge to do with antimicrobial use, antimicrobial resistance, and in general bacterial infections within COVID. I'm going to try and stay away from fungal infections today, and I'm not really going to pick up on viral co-infections either. So if we go back to early in 2020, when we were beginning to learn little bits about COVID-19, and we were anticipating it causing potential problems within the United Kingdom, there were a number of questions that came up and that many people were thinking. And one of those was in terms of bacterial infection associated with COVID-19 and the potential challenges this was going to pose to antimicrobial stewardship. Now, in terms of COVID, we had a condition that presented, particularly in patients presenting to hospital, with signs, symptoms, biochemical tests, and potentially radiology, which could be consistent with bacterial infection. We had limited data to describe the rates of bacterial infection associated with patients with COVID-19. And there was this real and understandable perceived risk based on our prior knowledge of previous viral respiratory pandemics, such as with influenza, where with influenza, we see reports of extremely high rates of bacterial infection secondary to influenza, and actually mortality often being associated with these secondary infections, as opposed to the initial, the viral infection. And one of the other challenges, I think, in terms of trying to pick apart some of the data that we've been provided with during the early phase of the pandemic in particular, was the way that we define and characterize bacterial infection in COVID. We'll see lots of different terms and definitions used, often interchangeably, whether it's co-infection, superinfection, secondary infection. And it was always really important to think about whether these are community bacterial infections or hospital-acquired bacterial infections associated with COVID-19. I think more importantly as well, there was a big question around whether these infections which we're seeing are directly attributable to COVID-19. So does the viral infection unmask certain features which make it easier for bacterial infections to take hold? Or are these infections which we see a direct consequence of the interventions which we implement to support patients with COVID? So are these healthcare associated infections in patients who are being mechanically ventilated or having lines inserted, for example? And finally, there was a question about how much of the change we were observing in terms of bacterial infections is how much is this caused by practice or pressures placed on the healthcare system. So as your healthcare capacity becomes overloaded, is this just a consequence of standard slipping or having to skip corners or missing certain infection prevention control practices, for example? And in terms of what we are aware of, there's some quite clear data now around antimicrobial use, drug resistance, and the impact of infection on COVID-19, as well as a significant number of outstanding questions. And so in general, we've seen that in the community, there's been a reduction in the amount of antimicrobials being prescribed. But equally, there's been a reduction in the number of notifiable infections. In hospitals and acute care in general, we've seen high rates of empiric antimicrobial use reported, but actually overall low rates of reported bacterial infections in patients with COVID-19. Within the intensive care setting, things have been a little bit different. We've seen again high rates of antimicrobial use, but also high rates of reported infections in patients who end up in the critical care environment. As the pandemic has moved on, so have our treatments and approaches to managing these patients, and we've seen the introduction of new therapies which have had variable success in the management of COVID-19. In particular, some of the immunosuppressive and immunomodulatory treatments which have been implemented have had significant potential risk of causing bacterial infection in our patients. And I think one of the most difficult bits to pick apart for us has been actually the variation we've seen in pressure placed on healthcare systems in terms of geography and time by COVID. So it's not been a linear pressure which has been applied continuously. It's waxed and waned over time with peaks and troughs which we've seen, which have varied not just geographically, but over time within the same area. And so being able to understand all those interactions and the impact of antimicrobial use and development of drug resistance in this context is incredibly difficult. And I think to make it even more challenging for us, there were no clear frameworks for us to be able to report data on this, which makes taking individual reports in the literature quite difficult to compare like for like and actually make clear interpretations. So what I'd like to do first of all is just go through some of the data that's already out there and sort of show you in a bit more detail the landscape that as we currently understand it in terms of antimicrobial use, bacterial infections and COVID-19. Starting with the community, overall, from data from the United Kingdom and the United States, we've seen reports of reductions in the rate of antimicrobial prescribing following the initial peak in cases within respective countries. It appears that these reduced rates of antimicrobial prescribing have been sustained post the tail off in COVID-19 cases, particularly in the United Kingdom, with the exception being actually in dental practice within the UK, where there were actually reports of significant increases in antimicrobial prescribing, particularly between April and July of 2020. However, wide regional variations were observed within this report. If we take a look at community prescribing across England, the figure here shows antibiotic prescribing per antibiotic item from March 2018 to November 2020. And as you can see where I've marked on the graph, actually around the time of the first and second waves of COVID in the United Kingdom, we saw significant reductions in the number of antibiotic items being prescribed within the community. And this correlated actually with a reduction in notifiable respiratory and non-respiratory infections in the United Kingdom compared to the 5-year average during the same time. One of my colleagues at Imperial, Dr. Nina Zhu, has done a lot of work looking at in great detail at community infections and antimicrobial prescribing during the pandemic within the Northwest London region in the United Kingdom. The figure here on the left shows in orange bars the number of SARS-CoV-2 positive tests per week between March and November 2020. The dashed blue line shows the anticipated or the predicted antibiotic items in terms of number of prescriptions based on 5-year averages. And the dark full blue line shows the actual observed number of antibiotic items being prescribed. And what you can see here overall is that there was a fall in community prescribing. And this was, as I discussed earlier, sustained post the fall in COVID-19 cases or positive SARS-CoV-2 cases within the community. Interestingly, during the very early phase of the pandemic in March and April, there was a slight increase in the use of drugs such as coamoxiclav. But when we look at the classification of drugs being prescribed in terms of aware classification, so the WHO aware classification, actually there was no change in the number of access drugs being prescribed compared to watch, for example. But I think the thing that I find quite interesting from this data are that despite about 6,000 positive SARS-CoV-2 tests within the community during this time period, about 1 in 3 of those patients still received an antibiotic prescription within about 14 days of the result of this test. And that's something we'll come back to a little bit later when we think about some of the modifiable drivers of antimicrobial resistance and the potential impact that certain actions and certain practices will have on in the future. I just wanted to add a small slide as well here about some of the changes which happened in acute care, particularly during the initial surge in cases in the UK in March and April 2020, for example. And we saw massive shifts in the way that healthcare was delivered and acute care was delivered, with the cancellation of routine surgeries, was trying to empty hospitals to provide capacity to be able to take surging COVID-19 cases, and the expansion of areas such as critical care. And an example of that was locally at the trust that I work in, we almost tripled our ITU bed capacity during the initial part of the pandemic. And in terms of the patients we saw the majority of individuals being mechanically ventilated. They required things like long periods of paralysis to support mechanical ventilation, to support lung protective ventilation, to allow us to prone them. And this led to patients having very long ITU stays as well. And interestingly, we saw a shift in the epidemiology of infections which we were detecting during this time period. And I've just put one example up here, which I think will probably ring true to lots of people from different areas. We actually saw a reduction in the detection of gram-negative bacteremias during this time. And there are a number of different hypotheses for why this was seen, probably because of reductions in routine surgeries and, for example, urological procedures being undertaken. But there was also a concern about whether part of this could have been due to mispresentations to hospital. So were people self-isolating at home with fevers, feeling unwell, thinking that they had coronavirus, when actually they had a gram-negative bacteremia, for example. And so a number of complex factors to take into consideration again when we think about what we're observing in acute care during this period in time within our hospitals. But when we look specifically at bacterial infection in coronavirus patients, there are now a huge number of studies which have been published, the majority of which were retrospective, reporting from hundreds through to thousands of patients with COVID-19 who were admitted to hospitals from different regions all around the world. And in general, there's a low rate of patients reported as having detected bacterial infection presenting to hospital from the community, somewhere around 3%. And overall, during the course of someone's stay with coronavirus, hospital-acquired bacterial infections in patients with COVID-19 was reported as rising up to about 15% at a peak. That's taking the overall population of patients within the hospital with COVID. In comparison to this, antibiotic prescribing was significantly greater, with reports of between 60 to 95% of patients receiving antibiotics during their admission for COVID-19. So overall, just to reiterate that, about 8% of patients admitted to acute care with COVID-19 would be diagnosed with a bacterial infection. About 72% overall would receive an antibiotic, and these were often quite broad spectrum in nature, with often carbapenems or broad spectrum fluoroquinolones being prescribed, and very difficult to understand the temporal relationship between the diagnosis of COVID-19, so a positive SARS-CoV-2 swab, for example, and that prescription, whether it came before, after, or throughout. Similarly, there was also regional variations in the rates of prescribing reported, as Brad Langford and colleagues demonstrated in the figure that I've placed here. But overall, regardless of the region, it's quite large rates of prescribing throughout different regions of the world. However, I should highlight here that despite there being numerous reports from high resource settings, from low resource settings, there was still limited data on practices and experiences, particularly during initial surges and cases. I also wanted just to highlight bacterial infection in critical care in a separate slide, because I think this is an important differentiation between the general hospital, acute hospital with patients being admitted with COVID. So in general, as we said, there were low rates of reported bacterial infection in patients with COVID-19. But there are now a large number of studies looking at tens to hundreds of patients who were cared for in intensive care units around the world, which have demonstrated significantly higher rates of reported bacterial infections within this patient population, ranging from anywhere from the 20% all the way up to over 50% of patients admitted to intensive care with COVID-19 developing an infection during that stay. The majority of these being ventilator-associated pneumonias, hospital-acquired pneumonias, or central line-associated bloodstream infections. And similarly, we once again saw high rates of antimicrobial usage in this patient population. Now, in terms of critical care and bacterial infection, I'm not going to go too much further into this because I think you will have already heard about this yesterday. But in terms of what the current data showed, there were high rates of healthcare-associated infections reported. And in terms of outbreaks, we've also now seeing reports of multi-drug resistant organism outbreaks being associated with these units. And I'm going to show you a little bit of that data in the next few slides. And it's also a very much changing situation during the pandemic. So early in March and April, we were very much providing supportive care for these individuals. But by the time November and January came around with second and third surges in cases, we were using a much broader range of agents to try and support patients and treat patients, including the use of immunosuppressive and immunomodulatory therapies for COVID-19. And it was really unclear how these factors were influencing the changes we're observing in bacterial infections within these populations. Furthermore, in terms of the literature that was being provided, there was very little data to compare baseline rates within units, and centres pre-COVID-19, which often makes interpretation of some of these findings quite challenging when you're just seeing a snapshot of what was observed during the pandemic. One study which did aim to look at this and comparing non-COVID to COVID patients, and which I think sheds a lot of insight, was one from Addenbrooke's Hospital in the United Kingdom. And the authors here compared 81 COVID-19 patients they managed to 144 non-COVID patients, all of which were ventilated on their critical care units. And I think fairly unsurprisingly, when you look at the associations with the COVID cohort, there are also a number of significant risk factors, which we often traditionally think of as risk factors for the development of things like ventilator-associated pneumonias. So most patients, or a significantly higher proportion of patients admitted to the intensive care unit, had the appearances of an ARDS type picture on presentation. A significantly higher proportion were managed prone, and that often requires the use of paralysis, which means that patients, have a number of risk factors which can be associated with that. Furthermore, there were longer stays on the intensive care unit and longer durations of mechanical ventilation. And I think all of these factors brought together makes it fairly unsurprising, actually, that there were more suspected and confirmed ventilator-associated pneumonias compared to non-COVID patients, therefore. However, I think the interesting point to take away from this was that if you look at the causative organisms, which were defined as causing these ventilator-associated pneumonias, as is demonstrated on the right side of the screen, with the figures showing likely causative organisms in colour, likely contaminants in grayscale, there were fairly similar causative organisms between COVID and non-COVID-19 patients. Similarly, the authors went on to look at the microbiomes of the lungs of these subset of COVID and non-COVID patients and demonstrate that the microbiomes also were not that significantly different, which suggests that these infections are more driven by healthcare exposure as opposed to any underlying change in pathogenesis caused by actually having COVID-19, so exposure of virulence factors, for example. And I think it's also important at this point for us not just to think about what we're seeing in terms of bacterial infections and antimicrobial use, but what the data out there is so far on outbreaks of multi-drug resistant organisms. And from early on in the pandemic, actually, a number of groups, including our own, have written some hypotheses about potential factors which could potentially drive outbreaks of organisms which are extensively drug resistant during the COVID-19 pandemic. And these ranged from, I won't go through them all in detail to read out the list, but it ranged from everything from changes in practice in infection prevention control, to changing in staffing ratios and levels, to capacity issues within the intensive care unit, to changes in antimicrobial prescribing practice. And we've begun to see some of these predictions now echoed in some of the initial data which has come out looking and investigating some of these outbreaks. So the data I demonstrate here was from one of the early studies by an American group in emerging infectious disease, who reported the outbreak of multi-drug resistant gram-negative organisms associated with COVID-19 wards in their hospital in the United States. And they actually report the observation of 3 multi-drug resistant organisms across 3 care units, associating these outbreaks with critical illness, high rates of antimicrobial use, double occupancy of single rooms due to capacity, the changes in team structure, so in terms of staffing ratios, and also changes in terms of infection prevention control practices. And that was in terms of gloving and hand hygiene, for example, as one of them which they highlighted, which was all put in place to protect staff from exposure to the virus in these high-risk environments. And we've also seen this reported from Europe now. And a recent publication actually was from 3 Italian hospitals where they compared 2019 to 2020 data over a 22-week period. And essentially what the authors reported here, that in 2020 they observed increased length of stay, increased length of mechanical ventilation, and increased meropenem consumption within their intensive care units on these 3 sites. And I think what was interesting here was that actually in terms of overall CP colonization and infection rates, these are actually quite similar. However, they saw a shift in the type of organisms which they were identifying, moving away from KPC organisms through to OXA48 and VIM types. However, what the authors did note was there was a significant increase in both colonization and infections with carbapenem-resistant Acinetobacter baumannii, or crab. And I've shown the data here in the figures on the right side of the screen, with the red bars being 2020 and the bluey purple bars being 2019. So as you can observe here, that in terms of colonization, there was a significant increase between weeks 12 and 19 in 2020, as well as significantly more infections with crab in 2020 throughout the 22-week period compared to 2019. So I guess this brings us back to the initial question. So what impact will all of this have in terms of long-term impact on antimicrobial resistance? And I think, if I'm honest, it's incredibly complicated. And until we have more data and more time to observe this impact and understand the regional and time variations, I don't think we'll truly be able to give you an answer, just because there's so much variation there. And there are some incredibly positive factors which we've identified from the pandemic: reduced rates of community prescribing, reduced potential for transmission within the community, as opposed to high rates of broad spectrum antimicrobial use and sort of failures in certain infection prevention control measures leading to transmission of multi-drug resistant organisms in hospitals, particularly in critical care, which is quite difficult to square up and understand overall how this will impact long-term rates. And so I think that the important thing is for us to focus on identifying mechanisms by which we can mitigate the impact of the pandemic on AMR. And what I mean by that is focusing on gathering evidence to help us shape our understanding and knowledge further, trying to understand more the actual impact that bacterial infection has on the outcome of COVID-19 to help us stratify areas where we need to be slightly more cautious in terms of being judicious for antimicrobial use versus areas where there's low risk to our patients. And therefore we can be more aggressive in trying to reduce antimicrobial use. And I think that this all needs to work towards how we develop guidance and clinical decision support to promote antimicrobial stewardship, whilst also working on maintaining standardized ways of developing routine surveillance for AMR in these difficult situations and continuing to support infection prevention control practices. And so what I'd like to do now is just focus on a few of those core aspects a bit more, and then try and bring it all back together at the end to talk about the impact of the pandemic on antimicrobial resistance. And so I think one of the most important questions we've thought about is, what's the actual consequence of bacterial infection in patients with COVID-19? It's obviously appears to be fairly low in patients in the community, appears to be fairly low in general in hospitalized patients, but in the intensive care setting, we're seeing high rates of hospital-acquired infections. And several studies initially to come out associated bacterial infection in COVID-19 with worse patient outcomes. And I think one of the challenges with these types of studies are that they're retrospective, they're observational, and they often actually only have a small number of patients who have a bacterial infection. And so this brings in a huge number of risks of potential bias. And then you also factor in the point that many of these studies fail to differentiate what part of care, particularly in acute care, these patients were managed in. Were all of these patients who had bacterial infections and died critically ill, or was there a mix of patients on the general wards versus those in critical care? And so it's important for us to try and understand those in more detail when we make sort of recommendations or we make considerations about the consequence of bacterial infection in COVID. I think one study that's been really helpful to try and start piecing this together was by Neil Clancy and colleagues in Open Forum Infectious Disease. Now, they looked at just over 600 patients who underwent post-mortem studies in 75 international post-mortems up to September 2020. And what their specific focus was looked at was to explore bacterial lung infections in patients with COVID-19. And as a sort of a headline result, what they found was that in terms of histopathology, there was potential superinfection with a bacteria demonstrated in 32% of these cases. However, only 8% of cases had what they described as a proven infection, with the remaining 24% actually being possible. So there was some evidence, but no definitive evidence of bacterial infection in these patients. Again, as with most of the studies which we see in terms of looking at clinical data, there was limited data on causative organisms. But I think the important thing to take away from this was that in terms of cause of death assigned to patients, only 3% of cases had bacterial superinfection assigned as the cause of death. Obviously, there are some caveats to this, including that in these cohorts, there are probably already high rates of antimicrobial use, as we've shown within secondary care. And if we're looking at patients undergoing post-mortem, this is obviously a very select population. But what I think it does is provide some evidence that overall bacterial infection isn't playing a major issue and a major part in outcome for patients with COVID. And I think to try and triangulate this a bit, we're now also seeing some really interesting data from RCTs. In terms of acute care, we had the recovery trial, which actually several months ago now, reported on the use of azithromycin in patients with moderate to severe coronavirus, comparing about 2,500 patients who received azithromycin versus over 5,000 patients who received just standard of care, demonstrating no clinical benefit, whether that's anti-inflammatory or antibacterial, in outcomes of COVID-19. But I guess one of the problems with looking at the recovery trial and trying to infer something in terms of antimicrobial use is that, again, we know that rates of antimicrobial use in general in patients admitted to hospital is very high. And so that standard of care arm may have also had high amounts of antimicrobial exposure empirically. And I think what's more interesting from this point of view is to look at the principal trial. Now, the principal trial is a UK-based study which looked at recruiting patients in the community who were diagnosed with COVID-19, and they were given randomized to standard of care versus interventions in the community to look at their progression of disease, hospitalization, and mortality. And two arms of the study looked at the use of azithromycin and doxycycline is an intervention for early in patients with COVID-19. And both of these studies have reported no meaningful benefit in terms of prevention of hospitalization, prevention of death, or actually speeding up recovery in patients in the community who were diagnosed with COVID, which I think again adds more weight to the fact that bacterial infection isn't playing a huge role in the progression and the pathogenesis of COVID. Another point to take into consideration is what's happened since the introduction of immunosuppression and immunomodulatory drugs to support patients with COVID, in particular steroids and interleukin-6 receptor antagonists. And I think there was some concern early on, actually, that observational data suggested higher rates of bacterial infection following the administration of some of these agents. And this was a concern here, therefore, that we needed to use more antibiotics to try and make sure that we prevent secondary infection in these patients following administration of these drugs. However, I won't go into this in too much detail, but just to say that at least from the randomized control trial data out there, looking at reporting of adverse events, and in particular secondary infections and sepsis following the administration of steroids, varying doses, and interleukin-6 receptor antagonists, there's been no observable difference in terms of rates of secondary infections in patients receiving standard of care versus the immunosuppressive or immunomodulatory agents. However, I think there's still probably more work to do on here to be clear on terms of what the risks are for individuals after receiving doses of these. Another point which has come out of the pandemic has been the focus on antimicrobial stewardship interventions. And I think these are potential positive impacts, which are actually going to have a much more significant impact into the future at trying to prevent some of the unnecessary antimicrobial use and the gaps in terms of things like diagnostics that we highlighted earlier on in the talk. One of the really strong points from quite early on in the pandemic was the guidance from the World Health Organization, which really focused on judicious antimicrobial use, and in particular not recommending antimicrobials, or antibacterials I should say, for patients with mild to moderate COVID-19 without strong evidence of bacterial infection. Furthermore, there's been a lot of research looking at things like clinical prediction rules to try and support decision-making around antimicrobial use in patients with COVID. And I think a really nice study, which was published by Mason and et al. In early 2021, looked at factors which can help exclude bacterial respiratory infection in patients with COVID-19. And actually, they were able to demonstrate that the absence of an elevated white cell count, I presume before the administration of steroids, as well as the absence of any antibiotic-related decrease over 48 to 72 hours after being given antibiotics at admission with COVID, together had a high predictive value of demonstrating no evidence of bacterial infection. And as someone who works as a microbiologist on call, a lot of the calls we often get are, we've given someone antimicrobials, their inflammatory markers have remained high and not responded to treatment here. We need to escalate, we need to change antibiotics. I thought this was a really nice study that actually flipped that concept on the head and actually says if you've not seen a response in these individuals with COVID-19 after 48 to 72 hours, it's probably because there's no actual underlying bacterial process going on here. All of what you're seeing is being driven by this respiratory viral infection and the body's immune response to it. I think another area where we've seen a rapid uptake and adoption of certain technology has been the implementation and use of procalcitonin, a biomarker which is more specific for bacterial infection and has reasonably good evidence of being able to help differentiate bacterial from viral respiratory tract infections, for example. And this is something, particularly in our centre in London, which was adopted quite quickly during the pandemic, and has had a real impact at helping us either stop or actually not start antibiotics on patients admitted with suspected or confirmed coronavirus, where the procalcitonin is in a low to normal range, once again having quite a significant impact at reducing antimicrobial use within our acute care setting. A final area which I think has really been helped and developed further by the pandemic is being tried to understand how we can use all of this data which we generate in a more individualized and smart manner to help decision making. And one area that we've actually looked at Imperial has been looking at whether artificial intelligence can actually be used to help support decision making around the risk of bacterial infection. And so this was actually building on some work that we'd undertaken pre-pandemic, looking at the use of supervised machine learning, which has access to our electronic health record data, and in particular pathology records, to try and help classify patients into those who are at low versus high risk of being diagnosed with bacterial infection based on the difference in certain biomarkers in daily blood tests. And actually, we've been able to apply this to data from patients with COVID-19 and demonstrate an ability to be able to differentiate those who are going to go on to develop bacterial infection versus those who aren't, helping to support diagnostic decisions. And actually, the way that we're trying to apply this now is, rather than looking at single time point analysis, looking at longitudinal analysis and seeing whether or not temporal surveillance can be applied to this system, using it as a potential trigger to suggest when someone is developing an infection or a higher risk, to guide not only decision making around antimicrobials, but sampling, for example. And there's a figure here just showing that for an individual patient who, from their admission and then admission to critical care, had actually a rising probability of developing positive microbiology in this case, which was defined as bloodstream infection. And actually, we can then set thresholds for triggers, which would recommend when this patient is at high risk of going on to have an infection. And actually, after the second trigger on the diagram, we see that patients has positive blood cultures for a Pseudomonas. So just a little bit of insight into some other work that's going on there, trying to look at how we link in some of that data which we generate during the pandemic and use it to support decision making in areas where actually there's relatively sparse evidence to support our decision making and generation of guidelines. But very finally, I just want to touch on that last point I made in the bullet points around some of the factors that can help us in terms of mitigating the impact of the pandemic on antimicrobial resistance. And that's improving how we collect data and undertake surveillance. And I think what I've hopefully tried to get across to you when we look back at some of the data about what we know in terms of the pandemic and bacterial infections so far is that a lot of the data is heterogeneous. And actually, when we look down at individual studies, there's variable reporting of microbiology, antibiotic prescribing, and clinical data. And this is presented in an unstandardized way. And often, actually, it's not contextualized into the pressures which are being placed on a healthcare system by COVID-19 at that time. So it doesn't take into account those time and geographical variations in the pressures that COVID-19 is exerting on your local environment. And so one way that we can try and address that is through developing frameworks through which we can report things like bacterial infection associated with COVID-19. And this is really trying to take all of those bits of data which are generated, whether it's routine surveillance, whether it's individual patient data, or whether it's data generated through responsive studies or investigations at the local level, and find a way of operationalizing those into a framework which is flexible for the different clinical settings which we're trying to investigate, takes into account differences in resources and staffing which are available, and also isn't just useful for reporting and our broader understanding, but can actually be beneficial to individual stewardship or infection prevention control teams within that local environment. And this aims to try and provide standardized approach to surveillance in terms of reporting, prescribing, and resistance in patients with COVID-19 or in settings where there is COVID-19 present. And it really needs to focus on agreeing on appropriate comparators by which we can support understanding of what changes are actually attributable to COVID-19. As we've said, it's important for us to focus on developing frameworks which can actually look between centres and regions as well, and that includes high and low resource settings, particularly areas where we still have limited data describing their experiences of the pandemic so far. And finally, it needs to be done in a way which is prospective to allow temporal trends to be assessed and understood. So in conclusion today, I hope that in terms of current evidence, I've tried to get across to you that actually there are quite wide variations in the way that we report COVID-19, the way we report antimicrobial use and antimicrobial resistance. But in terms of the key take-home messages, when we think about the potential impact of COVID-19 on, first of all, those modifiable drivers of antimicrobial resistance, and thus the sort of short, medium and long-term impact on AMR, overall, we're seeing low rates of bacterial infection in patients with COVID. The bacterial infections we do see are predominantly healthcare associated, and we're now beginning to experience increased reports of outbreaks of multi-drug resistant organisms, especially within these high burden critical care settings, which have been under huge amounts of pressure from the number of patients they've been managing with COVID-19. At present, there's very little evidence that bacterial infection is a significant driver of poor outcomes or mortality in patients with COVID. And early antimicrobials, particularly in the community setting or on admission to hospital, does not appear to influence the outcome. And I think that although I've shown you a small snippet, that the impact of immunosuppression and new treatment modalities to this management of COVID still need better characterization in terms of their potential risk of bacterial or other, so for example, fungal secondary infections. And I think that moving forwards, we need to begin to try and think about the long-term impact of the pandemic on AMR as difficult to predict. And actually, the best way to get ahead of it is to try and mitigate the potential impact that it's going to have and increase our understanding and knowledge as we go. And so I think that really boils down to some key core components, that we need to continue to focus on the core principles of antimicrobial stewardship and infection prevention control where possible, and that essentially we need to try and identify and maintain any positive impact that this pandemic is having on stewardship and antimicrobial resistance, while mitigating the negative impacts which we identify as we go. And I think that to support this, a real important point to take away is that we really need to try and develop standardized frameworks for the collection and reporting of data, not just on antimicrobial use, but also on the development of healthcare associated infections and antimicrobial resistance within COVID-19. So I'd like to thank you all for listening. I'd like to offer my apologies again for not being present today. I hope that the rest of the conference is enjoyable. And if you do have any questions, comments, concerns, please do feel free to get in touch with me. I'll be happy to discuss those with you further. So thank you very much.
Okay, thank you very much, Tim. I know you're not here, but it seems rude not to thank the speaker anyway, especially if it was a very clear and careful analysis of the situation. I should say when we planned this meeting in the autumn, we thought there were going to be all kinds of new patterns and problems of antimicrobial resistance. There'd be lots and lots of patients with long-term VAP and unusual fungal infections, but that obviously hasn't really turned out to be the case, although I think there are specific instances being reported in different countries, as Tim has touched on. There's a few specific questions have come in on KPC, OXA48, the use of PPE and the post-mortem superinfection studies. And we're going to pass those on to Tim, and you will get those ones answered. But I'm going to pass over to Brian Dwerden to make a few general comments on his thoughts on the matter, as Tim is not here. So, Brian, over to you.
Thank you, Mark. I did have the benefit of being able to see this presentation in advance, and I think Tim has done a really good overview, starting off with the concerns that so many of us had on the bacterial side at the start of this. What would be the risk for the bacterial secondary infections in COVID? What would be the impact on antimicrobial prescribing? And what would be the impact on resistance? And he's gone some way to it, as far as we can at the moment, to giving some of the answers. Quite fascinating. And to start off with the positive effects in the community, clearly there was quite in the UK a lot less antimicrobial prescribing during that first phase of COVID could be quite understandable in the fact that there was much less access to general practitioners during that time. People were really encouraged not to attend their surgeries, and I think there was less opportunity to be prescribed antibiotics. But whichever way, those certainly came down, except in dental practice. And again, of course, the dentists weren't actually performing much in the way of invasive dentistry. They were very limited in what they could do. So if people had infections that might otherwise have been treated by more invasive procedures, they were going to get antibiotics, and that came through in his work. It's interesting also that there was less infection reported generally. I suppose if people are being told to stay at home, not go out, not meet banned from meeting other people, banned from social activities and so on, then that prime driver for the spread of infection has gone. Human contact, less activity, less contact, less eating out, so there wouldn't be many gastrointestinal infections perhaps. In the patients who did get COVID in the community, there seems to be a very low rate of bacterial infection in those mild to moderate cases. Although a third of them received antibiotics, I think only about 3% actually were diagnosed with a community-acquired chest infection, perhaps an admission to hospital. And the study where azithromycin and/or doxycycline were used in general practice for these, in the community for these patients, showed no real benefit, which again is reassuring because it backs up what tends to be the message outside of the COVID circumstances of avoiding antibiotic use in what is clearly a viral infection, and this has carried through into this one. When patients got into hospital, again, somewhat differently, not unsurprisingly, 3/4 of them were given broad spectrum antibiotics. Only 3% of them had an infection when they arrived, and up to 15% acquired a chest infection when a healthcare associated infection during the hospital stay. And this is excluding the critical care patients. So again, that's a low number of patients with a proven bacterial infection. And I like the fact of highlighting the markers of inflammation and inflammatory response to say, well, if a patient's white cell count isn't going up, if its CRP is stable and PCT, use these to exclude infection to stop antimicrobials, or at least if they're not going up, not to change, not to swap and change and increase the amount of antibiotic exposure. That was all good news as far as I was concerned. So it was also particularly interesting that there were fewer gram-negative bacteremias, something that had been steadily rising over the last 3 decades in hospital practice, and yet fewer reported during this stage, showing perhaps the different population in the hospitals during this time. Obviously, a big focus on patients in critical care, and somewhere between 20 and 50% was said to have developed a secondary healthcare associated bacterial infection, mostly ventilator associated pneumonia, hospital acquired pneumonia, some with the bacteremias. And though that figure is similar to one quoted by Jonathan Edgeworth in his talk yesterday, in terms of the number of the proportion of cases in critical care who were deemed to have a serious bacterial chest infection. However, as one might expect, 90% of those patients were prescribed antimicrobials, more than the non-COVID ICU patients. And there was a suggestion from some work of a worse outcome with bacterial infections in some studies in these patients. So that looked a bit dubious because they were probably not very well controlled for other risk factors. None of that, I think, would be unexpected and be quite reassuring. The organisms were similar to you would find in non-COVID patients, again, somewhat fairly reassuring. And yes, there were there have been outbreaks, and perhaps there will be increasing outbreaks of multi-drug resistant organisms in these patients. You would expect it. The pressures are those that we recognise for some time. What I was pleased to see was the evidence accumulating that steroids and IL-6 inhibitors didn't seem to be significantly increasing the risk of bacterial infection. And again, that came up with Jonathan Edgeworth yesterday, because that was something that we did think might have happened. And it was nice to see some post-mortem evidence coming through as well, in terms of autopsy evidence. Cause of death listed as bacterial infection or contributory in only 3% of those. Again, maintaining the focus that it's the virus that was being the problem rather than being hugely compromised by the additional bacterial infections. But I did like his finishing area. What do we need to do? Better data, better surveillance, improved framework for reporting bacterial infections in these patients, standardized reporting, something that those of us who have been involved in public health microbiology for years want and have wanted over many. This is the same as you need for all serious infection problems, and particularly focused here. And the mitigation was, again, back to basics. Have the evidence, promote the antimicrobial stewardship, good surveillance, and good infection prevention and control practice. He was really emphasizing that these tried and tested things were still hugely important in the COVID era. So, Mark, have there been any general questions?
No, that they are. Thanks very much, Brian. They are very specific, so we're going to palm them off on Tim, because they are important, but they are quite specific to the literature that he talked about. So thank you very much. I should have said that Tim Rawson, or you probably read it off the first slide, is a clinical fellow in ID and Micro at Imperial College, and he works with Professor Alison Holmes at the Health Protection Research Unit, as you'll all have gathered anyway. So his interests are biosensor technology, and also something he just hinted at, artificial intelligence and machine learning, which may well come in and influence antibiotic prescribing and diagnosis in the future. But that's the end of that session. So thank you, absent Tim and Brian, for your commentary at the end.